gives me great pleasure to introduce Dr. Paul Pittaluga. It's a joke. I've introduced him now, I guess, for 6 years. We've heard a lot about him. He's going to be talking about update on varicose vein recurrence and its management.
Good evening, ladies and gentlemen. I would like to thank Dr. Kabnik, Dr. Almeida, and Dr. Van Vis for this invitation to be here once again. I will talk about the update on varicose vein recurrence and its management. I have nothing to disclose. Varicose vein recurrence after surgery is a common situation, and its traditional treatment consists in the surgical ablation of all sorts of reflux, which is usually more complex and aggressive than the first-line treatment, the primary surgery, especially for the inguinal reduced surgery with lymphatic risks. It's also well known that the outcomes are worse after reduced surgery than after primary surgery, especially for the repeat recurrence after treatment. In the same time, the recent evolution for varicose vein treatment enables us to use less aggressive techniques such as minimally invasive surgery, endovenous ablation, and foam slow therapy. Therefore, in 2012, we should go towards a less invasive approach to treat recurrent varicose veins. The first option can be isolated phlebectomy without inguinal reduced surgery. We have reported our experience comparing two groups of consecutive patients with GSV recurrent varicose veins. The first one treated by traditional extensive reduced surgery, and the second one in which the treatment was more focused on varicose reservoir by phlebectomy without reduced surgery at the groin. We didn't use any additional foam slow therapy during surgery. We have reported excellent midterm results with no difference for freedom of inguinal recurrence and varicose vein recurrence after treatment between both groups, but with better results for symptoms and aesthetic for the second group treated by isolated phlebectomy with a very important drop of postoperative complication from 6.7 to 0.5%, and with a very significant saving of the mean cost. The second surgical option, described by Creton, combined phlebectomy, limited reduced surgery at the groin for big neo junction, and foam, the use of foam for neovascularization. He reported good